Doc Heps here with UroCoach. So I wouldn't be surprised if you're a little scared, confused about prostate cancer with all this President Biden stuff going on. Why did he get diagnosed with metastatic disease? I'll give you my scoop philosophy on how to approach this and to try and prevent this from happening to you. Thanks for watching. Hey guys, it's Doc Heps here with UroCoach. So most men are kind of anxious, scared to talk about prostate issues. But now with former President Biden being recently diagnosed with advanced prostate cancer, I thought it'd be a good time to talk about prostate cancer and also go over the general approach that I take and my philosophy on screening for prostate cancer. We as urologists use PSA testing, which is a blood work test, to help guide us to assess your overall risk of prostate cancer. Oftentimes we'll get it yearly or every other year to see if it's changing and again, assess your risk for developing high-risk prostate cancer. There was a task force back in 2014 that said, hey, we don't recommend PSA testing in men older than 70. Urologists didn't agree with that. And the task force changed its recommendation somewhat, and urologists changed their approach as well. But bottom line is, PSA testing is important, just like colonoscopy is important. You don't want to overtreat, but again, you want to undertreat and miss advanced aggressive prostate cancer like former President Biden's was missed. The American Urologic Association has guidelines to give us some assessment of when the PSA is elevated. So for example, men in their 40s should definitely have a PSA of 2.5 or lower. The lower, the better. Men in their 50s, the cutoff is 3.5. Men in their 60s, 4.5. And men in their 70s, 6.5. Now, this is a guideline. These cutoffs are not absolute. There's guys with PSAs lower than that have cancer, and guys with PSAs much higher that don't have cancer. You have to look holistically at the patient. What does the prostate feel like? Does he have a family history? Has the PSA significantly changed over the past year? If your PSA is elevated, what oftentimes is the next step? And from my perspective, we often repeat the value, repeat the blood work to make sure this wasn't a goofball or aberrant artifact blood work. So if it remains elevated, the next step in my approach is an MRI of the prostate. An MRI of the prostate is an imaging study that gives us a three-dimensional picture of the prostate, tells us how big or small the prostate is. It'll tell us if there's any lesions within the prostate and how suspicious these lesions are. It doesn't tell us if there's cancer, it just tells us if there's a suspicious area in the prostate and if that area may benefit from being biopsied. It gives us a target to biopsy. The benefit of doing a biopsy is it's the only way to determine if there is cancer or if there's no cancer. And if there is cancer, is it a low-grade cancer, intermediate, or high-grade cancer? Former President Biden's case, he had a high-grade cancer, and you've heard of this Gleason score they talk about. Gleason was a pathologist that looked at men's prostates. In the past, they scored it 1 through 5, with the number 5 cells being the most aggressive, 1s being very low-grade, non-aggressive. So they've abandoned the 1s and 2s, and now we have grade 3, which is a low-grade cell, typically very dormant, slow-growing, doesn't tend to spread. Cells that are 4s and 5s have a more bizarre appearance on the microscope, and they have a propensity to spread. So depending on the type of prostate cancer you have, it may guide us as to the treatment recommendations. For low-grade cancer, which is generally scores of 3s, we don't recommend anything. We do something called active surveillance with intermittent PSA blood testing and maybe a supplemental MRI. If anything changes significantly, we may recommend a repeat biopsy. In gentlemen who have intermediate grades, maybe they have mostly low-grade cells, but a little bit of those intermediate number 4 cells, we might send off genetic testing, and that helps guide us to determine, hey, is the behavior of this intermediate grade leaning towards the higher risk group or the lower risk group? And lastly, if you have 4s and 5s or a predominance of these cells, then we call that high risk and generally recommend some form of treatment and further testing to ensure the prostate cancer hasn't spread. What's my approach? I recommend PSA testing, maybe a baseline in your 40s, and then depending on those numbers, every year or two, along with an exam to ensure nothing has changed. So if the PSA is elevated, oftentimes I'll repeat it, confirm that it wasn't a artifact, a lab error, and then if it remains elevated, we'll talk about getting an MRI of the prostate. If the MRI shows an abnormal lesion, oftentimes I'll recommend a prostate biopsy. If it comes back low grade, active surveillance. Watch it, monitor. Intermediate, oftentimes we'll get genetic testing to help guide us. It kind of depends on your age and your overall health condition. If it's high grade, oftentimes we'll recommend some sort of treatment and testing to reassess the stage to ensure that the prostate cancer hasn't spread outside of the prostate. Hopefully this video was helpful, provided you some insight at an anxious time when prostate cancer is in the news. Thanks for watching. Check us out, UroCoach, realurology.com. We'd love to hear from you. Make sure you subscribe, like, and comment. Let us know what you're thinking.